We'll move on to the next topic, which is rational antibiotic prescription in OPD. And who better than Dr. Kukureja, sir, to take this session? We've been enlightened by his knowledge regarding this for so many years now. And today again, we'll have the pleasure of listening to him. Welcome, sir. And I would be inviting Dr. Subhash Chandra to chair the session. Dr. Anshul, please, a neonatologist at Cloud9 Hospital, and Dr. Manazir. Dr. Manazir, sir, please, at AMU. Thank you. It's Dr. Kukureja, sir.
So, very good morning to all of you, and I am thankful to our team organizing for this important and wonderful conference. Today's topic is very practical and our use in day-to-day practice. And as we all know that importantly the use of the antibiotic and rational use of antibiotic is very important to save the future lives of our generation. So the antibiotic should work at least. It should not be like a allopathic. If patients come with us with fever, with chills, physicians or pediatricians start the Sapodam. Next day they come with loose motion, they start with the ofloxacin and metronidazole. So that practice we should stop it, and we should learn none other than my teacher, Dr. Shyam Kukureja, Director and Head and Department of Pediatrics, Max Super Specialty Hospital. So over to you, sir. Thank you.
Hello. Thank you, chairpersons. I think the organizers insisted upon this. This you have to do. I don't know the reason, but anyway, it's a very basic topic, but I'll enlighten you about this topic. See, it is important today to have a rational antibiotic practice. अच्छा, एक क्वेश्चन पूछते हैं before we start. आपकी OPD practice में कितने % बच्चों को एंटीबायोटिक मिलना चाहिए? Just guess. हैं? हाँ, अगर 5 to 10% से ज़्यादा में जा रहा है, it means कोई गलती तो हो रही है. Then there's a need for this CME. So it is very necessary. So let's discuss this. Now, why this is so important? This report, any intensivist or any neonatologist sitting here will vouch for me that this is not uncommon. We have got a child with Klebsiella pneumoniae and is resistant to everything. Not uncommon in today's practice. We see every now and then. Okay. Now, if you see WHO, CDC, every authority has been telling us we are almost entered a post-antibiotic era. And in what used to happen in pre-antibiotic era was even tonsillitis used to kill the patient. So we are sort of entering that era, and that's the worry. Now you see the annual growth of publications on antimicrobial resistance. People realized around 2007, 2008, oh, antibiotic resistance is going up. And now see the number of publications which have gone up. And with that pace, antimicrobial stewardship program is also being implemented in different parts of the world. See, this is the growth of that also. The publications are going up and up. It means before 2007 and 8, we were not too much concerned. We were not very judicious regarding antibiotic use because there was hardly any threat of antibiotic resistance. I think many times in our wards, our boss used to give in whims and fancies, give this antibiotic, and we used to start this without having rationalizing this. And in today's practice, it's very, very important to rationalize. Why it is so? Because the reason is the antibiotics, new antibiotics are not coming. So whatever antibiotics you have, you want to increase the life of these antibiotics, and you want them to use for a longer time as far as possible. If you misuse them, then there's a possibility that you won't have anything to use. Anyway, now this is a child, 1 year old, recurrent non-bullous multiple pyoderma. You can choose any drug, linezolid, cephalexin, coamoxiclav, cefuroxime, cipodoxime. Everything will work. But what will you choose? Cephalaxin you will choose. Okay, and see what's the reason? There are two types of impetigo, non-bullous or bullous. Non-bullous is because of group A streptococcus or MSSA. If you are very rational, you can do a gram stain on that. And if you are finding gram-positive cocci in chains, then it is group A streptococcus. If they are in clusters, then this is MSSA. If MRSA in impetigo is very, very low occurrence unless the patient is very sick. So I'll choose cephalaxin. Why I'm choosing this? Because it's a very narrow spectrum. We are talking just basic cases, prototype cases of 6-7 systems, and see what happens. Now here, what has happened, whenever I write antibiotics, I must answer this. What's the diagnosis? What's the likely bug? Is it virulent or not? What's the drug resistance in this case? What are the possibilities of drug resistance in this case? What is the host? And this should be, drug should be narrow spectrum. And we'll review this if we have taken culture after 48 hours, what the culture report comes. But in this case, we have not done a culture, so this is not valid statement for this case. So we'll answer this in most of the cases, and let's go on to the second case. Now, antimicrobials are only class of drugs which have a potential to treat individual, and as well as it will have an impact on the society as well. If there is a drug resistance, then the society is also affected. Tomorrow, the other people will get resistant bugs. Now, let's go into the second case. Classical lobar pneumonia, short duration fever, 3 days. Child has got chest pain, normal respiratory rate, bronchial breathing, crepitation. What's the drug of choice? Jaldi bolo. Amoxiclav nahi. Amoxicillin. Because the amoxiclav is going to cover beta-lactamase production. And staph pneumoniae does not produce beta-lactamase. So there's no need to use that. So we'll use this. So again, narrow spectrum. Let's go on to this third case. Now this is a child brought to me by doctor parents. And one of them is a pediatrician. 3-year-old male, fever 101, 102, coryza, cough for 2 days, throat congestion, and very precious child, IVF, oral ulcers around uvula, jugulo-digastric lymph nodes, recurrent tonsillitis, they tell me, there's a history of recurrent tonsillitis. Now this is a 3-year-old child with recurrent tonsillitis, which is very, very unlikely. Then throat culture is sent and they grow Staph aureus. So what they do is they start on cefuroxime. And the child keeps vomiting. They discuss with other doctors. They say, isko linezolid de do, because it's effective against MSSA. They gave it for 10 days. Child improved. And after 10 days, they get a throat culture repeat just to see that staph has disappeared or not. Now it is group A streptococcus. Now the whole story has gone absolutely absurd. We'll analyze this. Okay, we'll analyze this. It is stuck. Okay. Will you help me? Why it is stuck? Chal pada, theek hai. Now analysis of the case is, in the first place, the child had viral etiology, clear cut. There's a cough, there's coryza, there are oral ulcers. So it's no way it is a staph infection. And then you have rhinorrhea, cough, diarrhea, oral ulcers, hoarseness, very classical of viral. If it is bacterial, there's an absence of cough, swollen and tender cervical jugulo-digastric nodes, temperature will be 38, tonsillar exudates will be there, and the classical age group is 3 to 14 years. Okay, and now these are two criteria, Centaur and McIsaac. I won't go into that, which classically tell you that when it is viral and when it is bacterial. Staph aureus is normal part of a throat flora. It is not to be treated. There's no evidence that this organism causes acute pharyngitis. Never. So even if you, what is another organism you should be worried about in these cases? Diphtheria. Otherwise, staph is never a bug. Okay. And now you see a lot of prescriptions like this. The child, ENT people are very fond of cefaxime, Taxim writing in a patient of throat infection, azithromycin written because staph throat, even if it is staph throat, 25% resistance is there. Amoxiclav, there's no need to use it. And then you have children who are being treated with Klebsiella pneumonia, I've seen in my practice, being treated with Piptas. So no, you should not worry about any bug. I think you should go only for Streptococcus. And the other thing is you must rule out diphtheria in a sick, toxic patient. Now after throat culture, पेरेंट्स से चलो ये तो ठीक हो गया सर, हमने गलती करी है, अब आप ये बताओ इसका क्या करना है, ग्रुप पे स्ट्रेप्टोकोकस जो आया हुआ है, हमारी वरी है कि इसको रूमेटिक फीवर तो नहीं हो जाएगा. नाउ रूमेटिक फीवर is group A streptococcus in this patient is a carrier state. Can I ignore the report? Is the child patient at risk of rheumatic fever? Usually no need to treat carrier state because hardly it leads to any suppurative or non-suppurative complication. Even ASO doesn't rise in a carrier state. So there are special situations जहाँ पर carrier state का भी इलाज करना पड़ेगा. Can anyone tell me when to treat carrier state? Only two conditions, if there is a family or personal history of acute rheumatic fever, otherwise no. और normally जो हम rheumatic इसमें step throat में treat करते हैं, this is with amoxicillin 50 mg per kg divided into 2 doses into 10 days. The ceiling dose is 1 gram. And drug of choice to treat carrier state is basically it is very tough to treat. The answer is you have to give clindamycin because penicillin and amoxicillin will fail in 30% of the cases. Okay, so with this message we had was no overuse, and that's the reason मैंने बताया कि आपकी OPD practice में 5 से 10% patient से ज़्यादा antibiotic नहीं मिलना चाहिए.